Good morning, everybody. My name is Vicki Willie, and I'm co-chair of Track 1 with Dr. Lal this morning. Thank you for being here. I have the distinct pleasure to introduce Judy Sullivan, who is a consultant for Quality Source, a division of Blood Systems Incorporated. Prior to her position at Blood Systems Incorporated, she was the manager of accreditation programs at AABB, a position that she held for 9 years. She received a BS in Medical Technology from Seton Hall University and the University of Medicine and Dentistry of New Jersey, certification as a specialist in blood banking from the American Red Cross, Illinois region, and an MS in Human Resource Management from University of Maryland, University College. Judy has worked as a technologist and marketing specialist for orthoclinical diagnostics, a reference technologist at the American Red Cross, and the supervisor of the reference lab in the Department of Transfusion Medicine at the National Institute of Health. She is a past president of the Mid-Atlantic Association of Blood Banks and an adjunct professor at George Washington University. The title of her presentation today is Building a Competency Assessment Program that Works for All Blood Bank Staff, and I'm pleased to introduce Judy. Thank you for being with us today.
Thank you, Vicki. Thank you so much for being here. As Vicki mentioned, I am a Jersey girl, although I've lived in the Maryland area for about 30 years now, and it's just such a pleasure always to come back here. I actually remember 5 years ago standing in this exact spot, so it's kind of nice to be back. And now that Blood Systems has affiliated with the Community Blood Services here in New Jersey, I'm really excited about hopefully being able to work with some of our hospital customers in this area and kind of close that loop and kind of come back to my roots. So it's a pleasure to be here. One of the things that I do for Blood Systems as a quality source consultant is I spend a lot of time with our blood banks and help them get ready for inspections, assessments, surveys, whatever. So I've been doing a lot of coaching people about competency assessment programs. And what I saw was a couple of years ago, programs were all the way at this end, and now because accrediting organizations are kind of focusing on them, people have kind of jumped to the opposite extreme and have these huge, bulky programs that nobody can really administer very easily. So I'm hoping that today we can work on the Goldilocks principle. You know, not too little, not too much, just right. So we're going to define what competency assessment is. We're going to look at the regulations and requirements, and that I'm going to zip through. I figure I'm in New Jersey. I can speak fast, and you can listen fast. And then we're going to, hopefully the bulk is, how do you develop a competency assessment program that meets the needs of the blood bank? So first of all, here's the definition from CMS. Competency is the ability of personnel to apply their skill, knowledge, and experience to perform their lab duties correctly. And competency assessment is used to ensure that the lab personnel are fulfilling their duties as required by federal regulation. Now, why do we care what CMS says about competency assessments? Well, there's 4 letters that will tell you, CLIA. Okay, they are the people that are charged with administering and regulating the CLIA regulations. And they do that through organizations that they have given deemed status, AABB, CAP, Joint Commission, among others. And so why do we care? Well, the reason that we have to care is because in order to maintain their deemed status, the organizations have to show that they are providing appropriate inspections and assessments. And so there are validation assessments that CMS comes back after the fact to see whether they actually did their job right. And if they don't find the same kinds of nonconformances or deficiencies as the CMS people do, then it counts against them when they are redeemed. Okay, so when CMS says jump, accrediting organizations say how high. And right now, competency assessment is one of those hot buttons for CLIA. So it means that it is for us as well. How many of you in the past 2 years have gotten cited by your accrediting organization for your competency programs? Okay, they're focusing more and more on it. So let's go take a look at competency. So I remember going to an AABB meeting one time, and a nurse said, I just don't get this whole competency assessment thing. Why do we have to keep assessing competency? Once you're competent, don't you just stay competent? And I think all the blood bankers in the room kind of died a little. But it's not necessarily, okay? Number one, you've got staff that have been in your organization for 20 years, okay? We all have them. And you kind of get this complacency. Like I've been doing this forever. I find my own little shortcuts. I sort of start drifting away from my SOPs. Or you've got rotating staff. So either staff that, spend 1 week in blood bank, but then they're off somewhere in micro or chemistry and they don't come back again for another 7 weeks. Or so you get a loss of familiarity. It's infrequent. Or you've got techs, and I'm sure that a lot of you do, who work at more than one job in more than one hospital. And so how do you know that they are actually following your SOPs when they are in your hospital, rather than, oh, hey, I learned this neat little trick at this hospital over here, and I'm going to now bring it in, and I'm going to start showing other people this neat little trick as well. Okay, so what drives competency for lab staff? Well, not only is it the right thing to do, but it is required by regulation. And we're talking about testing personnel now, okay? And that is an important distinction. We're talking about the performance of laboratory tests, because that is what is regulated by CLIA. And so, again, we're going to go through this real fast. Everybody knows the regulations. Basically, you have to assess competency before someone can go forth and test independently. If the person fails their competency, then they have to have a plan for corrective action, okay? And you have to have 6 elements of competency, and these are the CLIA 6 competency assessment requirements. The technical consultant or the technical supervisor, and remember in CLIA, technical supervisor is a very different term than what we normally talk about as a technical supervisor. In immunohematology, a technical supervisor is an MD or a DO. Okay, and so the technical consultant role or the technical supervisor role, they are required to evaluate the competency of all testing personnel and ensure that they maintain their competency to perform test procedures and report test results promptly, accurately, and proficiently. And what are the 6 elements? Okay, we have to do direct observation of test performance. And if there's any kind of preparation of test samples that need to be done prior, that's part of that direct observation. So for example, if you have to do some kind of dilution of your test specimen before you actually do the testing, that needs to be part of the direct observation. You have to do direct observation of instrument maintenance and function checks. You have to monitor the recording and reporting of test results. You have to review worksheets, QC records, PT results, preventative maintenance records. You have to make sure that people have tested previously analyzed specimens, and you have to evaluate their ability to problem solve. And in the end of 2012, CMS came out with a competency assessment brochure and very specifically stated all 6 procedures must be addressed for personnel performing testing for all tests they perform. So you can't pick and choose. It's all tests they're approved to perform. You have to incorporate all 6 elements as appropriate. Who's responsible for performing competency assessment? Well, they say the technical consultant for moderate complexity testing or other individuals that meet the requirements for the technical consultant, the technical supervisor for high complexity testing, but it can be delegated in writing to a general supervisor that meets the qualifications as a general supervisor for high complexity testing. Now, you can use other individuals in the laboratory, but they have to meet the requirements for either the technical consultant for moderate complexity testing or the general supervisor for high complexity testing. If you have individuals who don't meet those requirements, they cannot assess competency. So what are the qualifications? For technical consultant, you have to have a bachelor's degree and at least 2 years of lab training or experience in the specialty in which they are assessing competency. So if you have someone who has no experience in hematology, even though they're a medical technologist, they cannot assess competency for hematology. Okay? In the blood bank, the general supervisor has to qualify as testing personnel, which means at least a 2-year degree, and have at least 2 years of lab training and/or experience in blood banking. You have to assess competency at least semi-annually during the first year the individual is testing specimens, and then at least annually thereafter, unless the test method changes, in which case you have to assess competency before that individual can perform testing independently. Now, some people don't understand this piece. You actually then need to assess competency 3 times in the first year the individual is testing. You have to assess competency before you say, go forth and test independently, and then twice in the first year. Okay? Notice also it says twice in the first year. It does not say at 6 months. So you can define when that interim assessment occurs and then annually thereafter. Also, this is a biggie, and I see this a lot when I go out and work with our hospital blood banks. Training and competency assessment are 2 separate and distinct actions, okay? And so documentation of training does not satisfy the requirement for documenting competency assessment. And that happens all the time. I'll say, okay, you've got a new testing personnel. Let me see their training and their competency records. And they give me one form. And it usually says either training or it says competency assessment on it. And I say, okay, so that's the training. Now, where's the competency? Well, it's in there. Or, okay, that's the competency, where's the training? Well, it's all in there. What CMS wants to see is, when was this individual trained? Because remember, during training, I can coach, I can correct, I demonstrate, I watch, I tell them when they've done something wrong. Okay, that's all training. But at some point, you have to draw the line in the sand and say, training is done. Okay, and I want to see the date and I want to see who trained. And now I want to see that they assessed competency. And so I want to see the dates of training and who did it. And I want to see the dates of the competency assessment and who did it. And I want all the dates of the competency assessments to be after the training dates. Okay, so you need to have documentation of both. They can all be on the same form. I don't care how you document it, but I want to see that this is when training ended and this is when competency assessment occurred. Okay, but now you have other staff or you have testing personnel who are performing other duties. So you have to assess their competency too, because not only is it the right thing to do, but it is required by AABB standards. Okay, because CAP and CLIA tend to focus on testing personnel. AABB standards talks about personnel performing critical tasks, because there are things that occur in the blood bank like phlebotomy, collecting the sample, or like issuing blood products, or possible component preparation, that are all critical tasks but are not tests. And that's, if I'm going to say this over and over, make sure you understand that testing is regulated by CLIA, tasks are not. Okay, so it's not just testing personnel that we have to worry about, or just the testing that testing personnel do, but there's also other critical tasks that occur. And so we'll talk about kind of how do we differentiate between those two in a competency assessment program. And again, AABB says the same thing. You have to assess competency before independent performance of assigned activities, and then at specified intervals, and you have to take some kind of action when competency has not been demonstrated. So here's the difference, okay? Testing personnel, when you are thinking about your people as people who are performing testing, you have to assess competency for all the routine tests they perform. All the CLIA elements have to be used for evaluation at CLIA-defined intervals. But now when we're talking about critical tasks, whether it's testing personnel or other individuals who are performing them, you define what you are going to assess, and you define at what intervals you are going to assess them. Okay, so when inspectors walk in the door, what are they going to look for? Do you have a policy that addresses competency assessment, training and competency? Who's approved to assess competency? And CAP is getting really big about delegating in writing. They want to see in writing that you have thought this through. How is it going to be determined? How are you going to assess competence? So what forms are you using? What procedures are you using? What tests are being evaluated? Remember, all tests the individual is approved to perform. How is it documented? And then does your practice match your SOP? Remember, new employees, you want to see competency assessment separate from training documentation and then assessed another twice in that first year. Incumbents, you want to see an annual assessment, documentation for everybody. And if the supervisor is also a bench tech periodically, that supervisor has to have their competency assessed for performing those testing activities. And then you should have some kind of statement that says, is this person competent or not competent? And if they weren't competent, what did you do? So there's evidence of that. And then does practice match your SOP? All right. So that was a down and dirty on the regulations. And I want to spend the rest of the time talking about how to build it without driving yourself and everybody else around you totally insane. Okay, so we're going to start with testing personnel because this is where you got to deal with the feds, and we, just like the IRS, we don't want to get on the wrong side of the feds, okay? So we're talking CLIA now. Okay, so step number 1, this seems obvious, define the tests. What tests do you perform in your laboratory? And this is pretty much a laundry list of what I generally see. ABO, RH, antibody screen, antibody ID. We'll talk about those two. Cross-match, DAT, antigen typing, maybe a fetal screen, maybe a Kleihauer-Betke, prenatal titers. Okay? Pretty much that is the menu of tests that are performed. And these are not tests. Okay? A unit confirmation is not a test. It is a process involving an ABO and an RH. Prenatal workups is another process that involves an ABO, an RH, and an antibody screen. Okay? Cord blood workups, not a test. It's an ABO, an RH, a DAT. Transfusion reaction, ABO, RH, DAT. Okay, so if you've got in your competency list, in addition to your ABO, RH, antibody screen, everything else, I'm doing direct observations of unit confirmations, prenatal workups, cord blood workups, transfusion reaction investigations, get rid of them. They are not tests. You're already assessing the ability of the individual to do an ABO, RH, antibody screen, and DAT. Okay, now you might want to incorporate them as part of your problem solving part of this, but it doesn't have to have a separate direct observation and all those kinds of things that are involved in it. Okay. Step number 2, define your methodologies. Okay, so if you do manual gel, but you also do tube backup, you need to assess both of those. If you have automation, but you use manual gel as a backup, you need to be able to assess those. So what are your methodologies? Okay, and make sure that we're incorporating the appropriate direct observations into our competency assessment. Then identify the equipment that is directly related to testing, okay, which in general is a cell washer, a centrifuge, an incubator, your ProView, your Echo. That's pretty much the equipment that we have in blood banking, right? Okay. Exclude equipment not related to testing. You do not have to do direct observation of high-low alarm checks. You do not have to do direct observation of preventative maintenance of your platelet incubator because they're not equipment that is directly related to testing. Again, if you're having problems with people doing PMs, you might want to put that as a critical task. But start with the tests and build your competency program around your tests. And then let's worry about the rest of it. So if those are on your competency assessment checklist, delete, 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 delete. Okay, now you need to assess preventative maintenance, okay? So what equipment requires preventative maintenance? What PM is required, how often, and who performs it? Because if you only do PMs on the night shift, you do not have to do competency assessment of preventative maintenance for your day shift and your evening shift, okay? It's just an NA. So you might want to put together some kind of matrix that says, okay, these are the things we do on day shift. This is what we do on evening shift. This is what we do on night shift. These are the individuals who have to perform all of these, so that I know which ones I have to do direct observation for preventative maintenance and which ones I don't need to worry about it. Okay, then design a form. Okay, so this is a very simple down and dirty for one ABO and RH tube test. And it incorporates all 6 elements into one nice little grid. So I'm going to do direct observation of testing. Well, at the same time, I'm going to watch the individual record and report the test results. And I'm going to put what the medical record number was for the patient testing that they did. When did I assess it? Who assessed it? Are they competent? If you have any kind of preventative maintenance, okay, so direct observation of preventative maintenance, and I'm going to review the record, because if they're going to do the PM, they're going to fill out the record at the same time, right? And again, what equipment, what preventative maintenance? I do not have to do direct observation of quality control. I just have to review the records. So while I'm doing my direct observation of ABO and RH, I go back through QC to the last time this particular individual did quality control, review it to make sure it is complete, and then put the date that the QC was performed on. If this individual did proficiency testing for tube testing anytime during the course of that year, I go back through my records and I say, okay, they did JA 2015 sample number 1, and I put it there, okay? And then problem solving might be some questions that you ask, or it might be a quiz, okay? But it's all one spot, and you can get a lot of it accomplished during the course of a single direct observation. So let's go back to basics. Let's look at direct observation of test performance and instrument maintenance and function checks. So, you say, well, okay, I got to stand here and watch the person do it. And yes, you do. I was just recently at a facility where they sort of tried to skirt the issue, and they said, well, I work with Annie all the time, so I'm kind of watching her while she's doing her day-to-day activities, so I know she's doing testing right. No. Now, you need to literally watch them do the testing and make sure that they are following the SOP, because otherwise you get into situations where I'm sitting doing my assessment and I'm watching somebody doing their testing, and I notice that they're adding 2 drops of anti-A, 2 drops of anti-B, 2 drops of anti-D, and watch them do the test, and then said, can I see the package inserts for your reagents, which say use 1 drop? So you've got to really do a direct observation. So you say, well, duh, of course they're going to do it right. Well, that's fine. You want what you want to do. I had one place say to me, well, our lab wants to announce when they're going to be doing direct observations. Isn't that cheating? Like, no. Have them, make them do their homework. Make them read over the SOPs. All you're doing is reinforcing good behavior. So it's perfectly all right to let them know ahead of time, I'm going to be doing a direct observation. It does not have to be a pop quiz, okay? But you can also do things like, explain to me, walk me through what it is that you're doing, or what would you do if? And remember, too, that during the course of the year, as a supervisor, there's nothing wrong with doing a little secret shopping and just kind of walk through the lab and watch what people are doing and make sure that when they know they're not being watched, that they're actually still doing things right. Okay, now, I always get the question, do I have to do direct observation of antibody ID? Okay, how many people think you do? All right, they're like, oh, this has got to be a trick question. Okay, so the question you have to ask yourself is the method the same as the antibody screen? So if I do tube testing and I'm doing antibody screens by tube and I'm doing antibody identifications by tube, what's the difference? 7 extra cells. Okay, so if it's not the same method, yes, I have to do direct observation. But if it's the same method, you've already looked at the antibody screen. I don't have to sit there and watch them label 12 tubes now and have to sit there and watch them do the rule outs. You as a supervisor should be Every time an antibody ID is done, you should be reviewing it, and you should be making sure that people are doing rule-outs correctly, that they're doing the antigen typing that they should, and you should be signing off on it. So I don't need to sit there and watch somebody do an antibody ID unless it is a different methodology from what I am doing. So if you run your screens on the Echo, but you're doing manual gel or you're doing tube testing for your antibody IDs, well then yeah, you do need to do the direct observation. So again, something else that you might be able to take off that list. All right, monitoring the recording and reporting of test results and review of worksheets, QC records, PT results, PM records. Well, aren't you doing that already? Hopefully that's something that you're doing on an ongoing basis. So you can include it as part of your direct observation. If they're doing a patient sample, they have to record and report test results. Boom, I've knocked 2 things off the list. Go back and look at that QC record the last time they did it. I don't have to watch them do it, I just have to review it. There's always a review of proficiency testing records, right? And you're always looking at antibody IDs and you're looking at panels. So this is something that you are doing, and then so you document it when the staff is either performing the testing or the PM. So going back to my little form again, when was the last time they did QC? When was the last time they did PT? You do not have to kill a gazillion trees, okay, and have all the backup documentation with their competency assessment. So you don't have to make a copy of the QC record. You don't have to make an extra copy of the PT record. My idea, my philosophy is make your inspectors and your assessors work a little bit, okay? There's some ways where you want to make sure that they have what they need, but you know what? If an assessor wants to say, okay, you say that this person performed QC on this date, let me see that QC record, let them ask for it. Okay? Now remember, if they look at it and there's something wrong, you're in trouble. So make sure that you have actually reviewed that record. But you don't need to kill a bunch of trees and have all the backup. You just have to be able, during an inspection, to make sure that the assessor can connect the dots when they need to, and if they ask for it. All right, testing of previously analyzed specimens. All right, this is always the one where we get into some problems because I've got 15 people who work in the blood bank or rotate through the blood bank. I don't have enough PT samples and blah, blah, blah. All right, so let's talk about that a little bit. So yes, you can use proficiency testing samples, okay? But remember that now you're having a little bit of overlap between PT and competency assessment, which we're going to talk about in a minute. But you have to rotate them among all the individuals that are performing testing, right? So it's a good source of an unknown specimen. But if you don't have enough PT, like for example, your DAT is what, 2-3 specimens twice a year. So even if you divvy them up, you only have 6 people who can do it, okay? But there's nothing wrong with taking a patient specimen and blind labeling it and then giving it to people. You don't have to make up positive DAT samples. It doesn't say that you have to test a positive sample. It just says you have to test an unknown sample and get the result right. So give them a negative DAT and see if they can get a negative DAT. For fetal screens, okay, you don't have to go mixing things up. Give them a sample from a male patient. And if they say that there are fetal cells in there, you know you have a problem. Okay, so again, don't make this any harder than it has to be. Make sure you understand the regulation and then hit the regulation. And until somebody tells you have to go further than that, you're good to go. There are competency programs, there's check samples and all that kind of stuff. So if you want to, spend more money and get more samples, that's fine. But, if you've got somebody say that you've identified a really nice anti-FYA that reacts 2+, well, go into chemistry, go into hematology, gather up as much plasma and cells as you can, and then give it out to your techs as an unknown, or 1 or 2 techs, whoever wasn't able to hit a PT sample. So it's really that easy. You don't have to be mad scientist, although I know sometimes we like to do those kinds of things. Okay, however, remember that when it comes to PT, we're also dealing with regulations related to PT, and CMS gets really upset if you mess with those regulations. So if, you get all this neat samples from CAP, and you say, well, okay, I'm going to give it to this person, and then when she's done with it, I'm going to give it to somebody else to do the testing, okay? You cannot do it, and CMS has come out with a directive to their accrediting organizations and their surveyors that you have to wait until the results are posted or whatever, they are public, before you can use those specimens. So remember that, even though they're nice little specimens, you've got to worry about keeping the two separate, because if you give it to somebody else to test before you get those results back, now you are not using those samples or testing PT the same way that you test patient samples. Okay. The other place where PT and competency assessment overlap is what happens if you give somebody a PT sample and they get it wrong. Okay, so it's a problem because of PT, but it's also a problem when it comes to competency assessment, because you have now deemed that individual incompetent because they didn't get the right answer. So you have to ask that question, is that individual competent to perform the test? No, they got the wrong answer. So you have to remove that tech from testing, you have to retrain them, you have to deem them to be competent before they can resume testing, and you have to have the documentation to show that you did exactly that. Okay, assessment of problem-solving skills, our last little piece here. All right, I would argue that antibody identification is problem-solving. Anybody want to argue with me about that? No. Okay, so you don't have to develop elaborate quizzes. If they're doing antibody ID, they're problem solving. And again, you are reviewing their antibody IDs. You are making sure that they are doing rule outs appropriately, that they've got 3 positive and 3 negative, or whatever your rules are, that they're ruling out in homozygous cells if that's what your rules are. Whatever your SOP says, you're looking and you are assuring on an ongoing basis that these individuals are competent. Okay, if they have to resolve an ABO discrepancy, okay, they are competent. So the problem solving that they do on a regular basis can be part of this competency assessment. Everybody in here does antibody IDs. I review them regularly. And obviously, remember too, but if there is a problem, you need to make sure you document it as part of that competency assessment. If your inspector says, well, let me see some of your antibody IDs, and they see problems with it that you didn't identify, you're going to run into problems. So you need to make sure that you're doing your job as well. You can use a written test or a quiz, 10 random questions every year. Please don't use the same questions every year. Eventually they catch on, that it's the same. You can use case scenarios. What would you do if? I had one place where they actually put the onus on the techs, and they said, I want you to have like a diary, and every time you do some kind of problem solving that involves testing, you write a narrative that says what it is you did, and that's part of their competency assessment. Okay. Remember, those who assess competency must also have their competency assessed if they perform critical tasks, and that includes the supervisor. No self-assessments allowed. I've actually seen that. Yes, I deem myself competent. I checked it all off, signed it all off. No, not going to fly. Okay. And remember, so any of your testing personnel, okay, that meet the requirements of testing personnel, hopefully they do or they shouldn't be testing, and have at least 2 years of experience in blood banking, can assess your competency. So be nice to them, at least the week before they're going to assess your competency. And they love it, they're just going to love it. Oh, let's make up some unknown samples, But make sure that if you are delegating that responsibility to other people, to the evening shift, to the night shift or whatever, make sure that A, they know what they're supposed to be doing. So you've got procedures, you've got checklists, whatever. And B, make sure that they understand that they have to be honest, okay? That this isn't a buddy system. I'll sign you off if you sign me off. That there needs to be accountability here in terms of if there are problems, then they need to report them. All right, so start with your tests, and we've kind of gone through that, and build your competency program around the tests, because that's what the inspectors are going to look at first. But now remember, there are critical tasks that we perform. So how do we assess competency for those? Well, have you defined what your critical tasks are? So you might want to just sit down and think about that for a little bit. Sample collection, sample evaluation, component preparation, issue of blood products. Are there other things that are happening within your blood bank that are not tests, but are critical tasks? So first, identify them all. You might want to decide which one you're going to assess by looking at things like deviation reporting. So we've been having ongoing problems with this particular task. If you have customer complaints, whether it is patients being stuck, whether it's doctors or nurses complaining about a particular task that's not being done in a timely manner, whatever. Staff complaints, things that your staff are complaining about, this is, we're running into problems with. Or high-risk activities, things that if they're not performed correctly could have an adverse effect on the patient. Or low-frequency activities, things that people don't do very frequently, but you need to make sure on an ongoing basis that they're competent to perform those tasks. But you decide. So you don't have to assess every critical task every year. If you want to, go for it. But you decide. Okay, which one? So you could have a rotating list and say, I'm going to do, these two this time and these two the next time, or we've been having a real problem with this, so this year we're going to assess this. You decide what it is that you're going to assess. And then how frequently do you assess it? You decide. Okay, it doesn't have to be every year. It can be on a rotating basis, but define it somewhere in your competency policy that says, how do I manage assessing the competency to perform critical tasks? Okay. Remember, even with critical tasks, there needs to be documentation of what was assessed, who was assessed, what method did you use, and you don't have to use all 6 elements. Remember, you decide how you're going to do it, who performed the assessment and when, and is the individual competent or not? And if they're not competent, what did you do about it? And something else that I would strongly suggest, I have found places where when they do their competency assessment, there is a self-assessment column and then a competency assessment column. Okay, and I have a real problem with that because, first of all, it's not required by regulation. Number 2, if a tech says, I don't feel competent, and they put that on that form, then why were they doing that testing to begin with? If you want to do self-assessments, that's fine, but keep it separate from the stuff that you have to show inspectors. Okay? Again, you show them exactly what they need to see and nothing more, nothing less. Okay? If somebody does have an unsuccessful competency assessment, you have to have a process for remediation. So again, remove that employee from testing until competency has been demonstrated. Keep in mind PT failures. Remember to document the retraining. If it reoccurs, document that. You have to have a reassessment. And then at the end of each one, is this individual competent or not? And hopefully at the end, it's either they're competent or they're fired. But they can't continue testing if they are not competent. Okay, remember, documentation has to be trackable and traceable. You can't just have a spreadsheet that says, I assess Jane's competency on this date and she's competent. You need to have the details. So what direct observation did you do? What record review did you do? The PT, or if you used an unknown specimen, what was the unknown specimen? If it's a graded quiz, that needs to be part of it. Who did the assessment? When did it happen? Who was the person being assessed? I love it when I get paperwork that has no name on it. Like, who was this? Oh, I think that was Jane. Okay. And then some kind of final determination of competency. So there should be some kind of final sign-off by the supervisor, by the individual performing the competency, if it's somebody other than the supervisor, the employee, and some kind of statement. that says, I certify I'm fully trained and competent to perform the role, and then, somebody saying that I attest that the staff member is fully trained and competent to perform the role, the test, whatever. Okay, so now we're done, right? Well, no, not really. Because remember, there's that other piece in the regulation that says if I have a change in test method or instrumentation prior to reporting patient test results, you have to reevaluate the individual, including that use of the new test methodology or instrumentation. Now, in this particular case, so say you have gone from tube testing to gel testing. Okay, this would be an instance where you would need to assess that competency before that individual would start doing the testing. But you don't need to then assess competency twice in the first year. So there's nothing in the regulation that says that you have to do that. But absolutely, before that person starts testing, there needs to be documentation of competency assessment. Okay, and now what about revised procedures? Well, it's going to depend. Okay, if it's a minor change in a procedure, it may be, read and sign. Or it may be you perform an in-service and everybody reads and signs. But if it's a totally new test, then there should be documentation of training and competency assessment, including direct observation. So, lessons to learn. Okay, know what the requirements are. Make sure you understand what the requirements are. Focus first on tests and make sure that you incorporate those 6 elements into all of the tests the individual is approved to perform. Don't forget non-testing personnel or individuals who perform critical tasks, but remember, you've got a lot more flexibility when it gets to there. And I know this seems strange to say, but do try and keep it simple. And hopefully we've weeded out some of the stuff that you incorporated into your program that is really just kind of repetitive and really doesn't need to be there. And again, keep it simple, keep it clean, connect the dots for the inspector, but again, don't kill all the trees by providing all the backup documentation. Let them ask for it if they want to see it. So, words of wisdom, somebody remember the Peter principle. In a hierarchy, every employee tends to rise to the level of his level of incompetence. Work is accomplished by those employees who have not yet reached their level of incompetence. So hopefully with a good competency assessment program, we make sure that we never reach a level of incompetence, and we have people who can do quality work, who provide the best possible patient care, because at the end of the day, regardless of regulations or whatever, we want to make sure that we're getting the right blood to the right patient at the right time and the right dose and the right product. And so, it's all about the patient is the bottom line. And my final word of wisdom, whatever you do, always give 100%, unless you're donating blood. Okay. Okay. Here's my email address. Feel free to send comments. I also wanted to mention, Dr. Liebeck had talked about TSOs and transfusion safety officers. Blood Systems actually offers a transfusion safety officer training program. It's a 3-day program, and it's usually held out in Scottsdale in the middle of the summertime, because that's where you get the cheapest rates. But it is a for-fee program, but we've been doing it now for 3 years and have had some really amazing results, because after our people graduate, they actually have ongoing phone calls and meetings and share success stories and those kinds of things. So there is a fee that is involved in it, but if anybody is interested, shoot me an email. I'll get you in contact with the right people. You do have to apply, and if you're really serious about bringing this kind of role into your hospital, it has been a very valuable kind of training. So I thank you for inviting me to talk. I hope you got some kernels of knowledge, and I hope I get a chance with our new affiliation to be able to work with you all instead of doing your real AABB assessments, helping you to get ready for the one that is coming up. And so, let's see, do we have time? A couple minutes for questions. See, I told 58 slides. I can talk fast. You can listen fast. Yes, ma'am.
Hi, I just have a question. How, with so much, multi-hospital systems, a lot of competency programs So obviously lab-the-brainer. Any comment on that? And comment on more esoteric tests, specifically elutions, HPC, worms, and how would you approach even just VRX testing?
Okay. So VRX testing is considered moderate complexity. Okay, so yeah, you would need to incorporate all those 6 elements. So the first question was about hospital systems. You know, I am a firm believer that the more you can standardize things across the system, the better off you are. But I also know that when you do that, it's like herding cats because every hospital wants to get their input in there. You know, sometimes somebody has to be the voice of reason. But there's nothing wrong with standardizing it as long as it hits everything in each one of the hospitals. So if there are specific tests that are performed in one hospital but not another one, that program and the one that does the testing needs to get included in it. In terms of esoteric tests, okay, so nobody tell Holly that I'm saying this. Holly was my boss at AABB. Oh, great, and I'm being recorded. Okay. My suggestion is start with the basics, okay? Start with the basic tests, okay? Warm autoadsorptions, elutions, they are not tests, they are processes in antibody identification.
Consider that preparation of the specimen.
You could, okay, and that would be a good argument for it. But my suggestion would be, if you're really struggling with your competency program, keep it simple right now. Keep it to the basic tests that you perform, okay, and then send it out there and wait for your next inspection. And if they say, yeah, but you also need to add, well, then go ahead and add them there. But I would keep it as simple as possible, you know, using the parameters that we discussed, and then see what happens. You know, the worst they're going to do is write a nonconformance. Well, you know, that's not the end of the world. So, any other questions? Yeah, I know, the ones are saying, yeah, except when my hospital administrator says if I get any deficiencies, they're going to fire me. Hopefully not. Any other questions? All right, well, you have my email address. I would love to hear from you, please, because the emails that I normally get are the ones from corporate office out in Scottsdale that say things like, we're cleaning the refrigerator on Friday, or the one that says, the massage guys are here. I'm like, I'm in Maryland. Where's my massage? You know. So feel free if you have any questions. And again, thank you for inviting me, and I hope to be back again in a future meeting.